Welcome, everybody, and thank you for joining us for today's webinar. We are honored to have Dr. Jillian Rork presenting for us today. Dr. Jillian Rork is a pediatric dermatologist at Dartmouth Health in Manchester, New Hampshire. She's also a clinical assistant professor of dermatology and pediatrics at Dartmouth Medical School. She grew up in New Hampshire, attended Dartmouth College, where she majored in French, and then Harvard Medical School. She is passionate about all things skin and Down syndrome. She specializes in treating individuals with Down syndrome and also promoting education and research in this area. Dr. Rourke loves reading, playing the saxophone, fly fishing, trying new foods, and hanging out with her husband and two kids. Thank you so much for joining us today, Dr. Rourke. We're honored to have you here with us.
Oh, thanks, Michelle, for having me. It's nice to see everybody. I'm going to envision you guys all hanging out with me at my house and not in this weird Zoom tunnel that we're in. So we're going to talk about the skin, this because the skin is in and always has been in our loved ones with Down syndrome, but maybe has not been talked about that much. So I do not have any conflicts of interest. I will be discussing off-label treatments today because so much of what we use is off-label, but I'll contextualize that when that's the case. So um, I gave part of this talk at the NDSC. It was a little wild this year because we had a very small room and got started late. And so some of you guys might have heard parts of this talk, but we're going to do the full version today. So our roadmap is going to be split between the clinic and the lab. And in the clinic, in the dermatology clinic, we're going to talk about the big six diagnoses that I see in children and adults with Down syndrome. And then in the lab, we're going to highlight how certain research projects have helped us understand more about those big six. So the big six that I see in clinic that we're going to chat about are dry skin, dandruff, psoriasis, alopecia areata, folliculitis, and hidradenitis suppurativa, or that is a mouthful, so I often say HS. And then we're going to talk about foot fungus. So before I get started, I just want to start with an announcement that there are now standardized skin handouts available online for free to the Down syndrome community. This was a long-time project between LuMind, IDSC, and the Pediatric Dermatology Society. So this is the QR code to these patient handouts on skin conditions, and these are really written for patients and their caregivers. Um, I will also tell you that, and I know my Google searches are different because, whatever Google gets to know me, but I'm pretty sure that if you type in SPD, which stands for Society of Pediatric Dermatology, Down syndrome skin handouts, you're going to be able to find these. And so this is the drop down right here, resources for patients with Down syndrome. And we basically built these handouts with the help of the Society for Pediatric Dermatology so that not only that you could become informed on skin conditions that are common in people with Down syndrome, but that you could also hand them to your local care providers, either a general pediatrician, internist, geneticist, or a dermatologist, so just so that they're aware of these skin conditions. These are highly edited, revised, vetted handouts that go through multiple committees in the Society for Pediatric Dermatology. So we really try to strive for not only accuracy, but appropriate reading level and just ease of understanding. So some of the specific skin conditions that we have handouts for are the ones we'll talk about today. So Down syndrome and folliculitis, Down syndrome and HS. We have life stages handouts, so highlighting common skin conditions in infants and toddlers with Down syndrome, in school-age children, and then in teenagers. And I would love to have an adult handout, but because this is through the Society for Pediatric Dermatology, we could not get one sponsored immediately, but we're working on that. So with all of that said, I hope you guys find those resources available and accessible and easy to use. And I'm going to highlight each of the major handouts as we walk through the clinic diagnoses. So let's start first with dry skin. And we have a Down syndrome dry skin handout. This is the QR code for it. So dry skin can look a little different in kids and adults with Down syndrome. It oftentimes involves their hands and is like a very, very dry, kind of thicker dry skin, especially over the backs of the hands and the knuckles. You can see more pictures here. Also see it a bit more on the tops of the feet and the ankles. And then we do have more kind of garden variety dry skin on the trunk. This picture is showing it here on the back. And then again, this thicker dry skin, oftentimes on the knees and on the elbows. We call this specific, like really, really thick dry skin, something called hyperkeratosis. You don't need to remember that. We're just going to come back to that in a bit because we treat this type of dry skin very specifically. Calluses, I would also say, are really, really common. And I think this has to do with having an easier time with dry skin, but then also the impacts on bones and mechanics of walking that can translate to calluses on the feet. So again, we're going to come back to these like really thick, thick forms of dry skin, hyperkeratosis. But there's a specific pop-out window on the dry skincare Down syndrome handout that we did that chats about this too. Okay, so you're always taught that when you have dry skin, you need to moisturize, right? Um, but it's like, yeah, well, that's great, but with what? There's so many products, it's so overwhelming, it's also very expensive. So I want to give you guys some base education on moisturizing products. So first, not all moisturizers are created equal. They come in 3 different strengths. I talk about this all day long in my regular practice too. So lotions are the weakest form of moisturizers. Creams are in the middle, and ointments and oils are the strongest. So to tell the difference between them, they oftentimes are labeled lotion, cream, ointment, or oil. But lotions, they're often in a pump bottle. They're the thinnest moisturizer with a higher water content, and they oftentimes will have a component of alcohol in them. So for that reason, they oftentimes can hurt on open skin, which is a very common complaint that I hear in my office. So in general, I'm not a huge promoter of using lotions in many people with Down syndrome who have dry skin. Of course, I see the more severe cases as a dermatologist, but in general, lotions aren't always the best option. I oftentimes recommend creams, okay? They're thicker than lotions, but they're not quite as sticky as ointments or oils. When you rub them in, they vanish pretty quickly. Ointments and oils, while they are the thickest, they have the highest chance of not hurting, which is very, very helpful and important to remember. And they are the best moisturizers, so you get the most bang for your buck. I oftentimes say, and kids and adults will laugh at me, that you don't need to put moisturizer on like cream cheese on a bagel or frosting on a cupcake. A little goes a long way. And a lot of patients will complain or be resistant to wanting to put these products on because they just feel so sticky or they're hypersensitive to touch or things going on their skin. So really trying to focus on not putting a lot on, a little goes a long way is a very important thing to remember. This is not on the slide, but I will say that there's an expanding brand of spray moisturizers, like specifically Aquaphor makes a spray moisturizer that I've had a lot of patients like too. Those can sting a bit more, but if creams or ointments or even a lotion just seems like a really tough thing, there are spray moisturizers available now. So the next thing I want to teach you guys is that just because it says all natural or organic does not mean that it's necessarily like a better moisturizer. And I like to consider myself a very holistic practitioner who does not just want to write prescriptions for everything, but we have to be very careful with how products are labeled. And I oftentimes will joke, well, hey, guess what? Poison ivy is all natural and organic, and we're not going to go around spreading that on our skin. So the next thing I want you guys to be cautious of is just because a product says baby on it, it does not always mean that it's great for sensitive skin. There's actually a lot of potential chemical compounds that are in baby products that make things sting-free, or preservatives that gives them longer shelf half-lives. So you just have to be very careful about that. I would also say that when something says baby on it, it's like attaching the word wedding to booking any kind of party, that the price just skyrockets. So baby products don't necessarily mean better products. So I am not endorsed by anybody in industry, and in many dermatology talks, I'm not even supposed to talk about products, but I'm just trying to be like practical and useful to you guys. And these are oftentimes products that I'll chat about in our office. So Cetaphil and CeraVe, those are very kind of long-standing products that are overall pretty easy to find in most grocery stores, pharmacies, and box stores. I will tell you that like Walmart and Target, they make generic moisturizing creams that for most people are very comparable to Cetaphil and CeraVe. Vanicream is now more easily available, especially carried in Target and at most drugstores, and that is a good brand. And then Eucerin. Some of the ones that are missing from here that just through the years, some people do wonderful with Aveeno. I've had other people have more issues with that because they do tend to have more colloidal oatmeal in their products, and sometimes people have a hard time with that. And then Aquaphor, sometimes people have a harder time with the lanolin that's in that product. But the big thing is you just have to find something that works well for you and works well for your budget. But I hope that that's a helpful platform to work with. Here are some of the fragrance-free ointments. Vaseline, coconut oil are common ones that we chat about. CeraVe and Cetaphil also make healing ointments. And then Aquaphor is another one. Theraplex is it's more of a subspecialty ointment that I use a lot for people who have very, very severe dry skin or have atopic dermatitis. And this is definitely more of an online Amazon find, but it is an excellent heavy-duty moisturizer. So just some quick bathing tips. So I get a lot of questions about bathing frequency. Is bathing every day okay? Is that going to be bad for my dry skin? And the answer is we think daily baths are fine. It's just as long as they're not in super hot water and for more than 10 minutes, and that you moisturize after. For many of my patients with Down syndrome, baths happen once or twice a week, which is also okay when it comes to dry skin. Okay. But just try to limit them if you're taking them frequently to 10 minutes. Thinking about using a cleanser or fragrance-free soap. Um, very bubbly soaps have a lot of surfactant in them, and they can remove moisture from your skin, so not over soaping. And then thinking about only really washing the dirty parts of your body or the smelly parts of your body. You don't necessarily need to get a full bubbly lather all over your body every day. That is probably going to dry your skin out. And there we go. Try to avoid those bubbles. In terms of order of how to bathe and how to put on moisturizer, we oftentimes say you're going to take your bath or your shower first, you're going to pat dry your skin, and if it is possible, to put moisturizer on after that. If that is not doable, that's totally fine, but it is helpful to have the skin have a little bit of dampness to it when you put on your moisturizer, because you can think about the moisturizer just locking that extra moisture in. There are wonderful bathing pictorial decks available through the Advocate Medical Group, the Adult Down Syndrome Center. This is the QR code to those pictorial decks, and then I just put in a sample of some of the pictorials that they have available for free on their website. So we use these quite a bit in my clinic. And I also love they have all different skin types on here, which is so wonderful. And I really try hard in my talk to show different skin conditions on all the different skin types, because I think that that's something that we need to do a better job of in dermatology. So check that out. So jog back to hyperkeratosis, that like super duper dry skin, elbows and knees. So there are over-the-counter moisturizers that are more targeted to this thicker type of dry skin. And here's a couple of common brands. What these moisturizers have in them are called keratolytics. These are ingredients that help really soften harder areas of dry skin. So for example, amlactin has lactic acid, CeraVe has salicylic acid, and Eucerin has urea. All good like softening agents for very thick dry skin. So for those elbows and knees, or even really thick spots on the bottom of the feet, top of the hands, top of the feet, we'll oftentimes chat about these super specialized moisturizers and think about just using them once nightly in the beginning because they can be kind of irritating if you use them too frequently because of those like softening ingredients. So let's move on to dandruff. And when we get to that topic, I want to jog us away from the clinic and go over to the lab for a minute. Okay. So we're going to just briefly chat about a little bit of immunology and Down syndrome because I think you're going to see how the immune system is linked to the skin after we chat about this. So just very basically, Down syndrome's 3 copies of the 21st chromosome. So our question is, so what genes are on the 21st chromosome? So there are quite a few genes on the 21st chromosome that affect the immune system, okay? And if we think about real basically what the immune system is, it's a really complex network of cells and organs that protect us from disease by recognizing and responding either to germs like bacteria, viruses, fungus, or actually unhealthy cells in our body. So we say thank you to that, the immune system protecting us from badness. But I will tell you, if you have too much of the immune system, so when there's 3 copies of those immune system genes, what happens? Okay. So people with Down syndrome have a dysregulated immune system because of these extra copies of some of these immune system genes. And it gets super complex. And I tell you, if anyone tells you that they completely understand this, I don't know if I believe them because it gets very, very complicated. And I oftentimes say, trying to understand the immune system is like alphabet soup and just trying to piece together all of these terms and how they relate to each other. Okay. But what I would really like to chat about just for a minute is a specific part of the immune system that is encoded on the 21st chromosome called interferon. And there's been a lot about this lately, especially with all the good work that's been done out in Colorado. Okay. So, interferon, if we think about that part of the immune system, I like to think of it as like a Harry Potter messenger owl. Okay. Interferon is an immune system messenger. It chats with lots of different parts of the immune system. Okay. So, in people with Down syndrome causes increased interferon signaling. So, with people who have 2 copies of the 21st chromosome, this might be how many messenger owls they have. But when you have 3 copies, this is how many messenger owls you have. You have a whole lot flying around. Okay. And with that increased interferon signaling, we think that that really can lead to immune system dysregulation. Okay. And when the immune system's dysregulated, it can cause issues in our body like autoimmune conditions, which we know people with Down syndrome have more autoimmune conditions. And I apologize if anyone is an immunologist or scientist on this call. I'm just trying to really break it down to building blocks, just so that we can all kind of see how amazing this is when we think about the skin conditions that we see. So when we think about autoimmune conditions in people with Down syndrome, right here on this diagram, we see a bunch of skin things pop up, right? Alopecia areata, we're going to talk about that momentarily. It's a hair loss condition. Hidradenitis suppurativa, we're going to get to that. That's on the list with thyroid conditions, type 1 diabetes, celiac disease, okay? So the immune system causes many skin conditions, and we think some of the dysfunction with interferon leads to more dandruff or seborrheic dermatitis, leads to more psoriasis, more alopecia areata. more of this folliculitis and HS, more of the toenail and foot fungus. So there is a lot of thought and energy going into how the skin tells us more about the immune system in people with Down syndrome. And the epicenter for this right now is out at the Linda Cernick Institute. Because I think we're really realizing that the skin is an open window into understanding some of this dysregulation. So with all of that said, let's jog back over to the clinic, okay, and chat about dandruff. So we have a handout about dandruff. It's also called seborrheic dermatitis. It's not Down syndrome specific, but all of this information is excellent, and you can find the handout on the Society for Peds Derm website. So dandruff can happen in many places. It can happen on the head, which is where we're most familiar with it, okay? It can, when it's more severe, cause hair loss, which we can see in this 12-year-old with Down syndrome that she's had thinning of her hair, really because of the severity of her dandruff. But this is really important. Dandruff can happen other places on the body, okay? It can happen in the eyebrows, in between the eyebrows. It can happen on the cheeks. It can happen in your armpits and in your belly button, and even sometimes in your groin area, especially if you're a baby, okay? So this is oftentimes a very undertreated, underappreciated condition in so many of my patients with Down syndrome. I'll have people come in for other skin issues, and it's like, oh my goodness, you have horrible dandruff. And it's oftentimes said, well, that's just never really been addressed. But this is, for many people, an easily treatable condition. So let's go through, what works. So over-the-counter shampoos can be helpful. Okay. Tea tree oil can be helpful for dandruff in the shampoo form. There's other anti-dandruff shampoos like Selsun Blue, Head and Shoulders, Dove. There's keratolytic shampoos, which are shampoos that lift off scale. A common brand that a lot of people will hear of is like Neutrogena T-Cell. So those are open and available. But I think it's very important to know that there's actually prescription anti-dandruff shampoos. The two main ones are ketoconazole and cyclopirox. Okay. And then sometimes when the dandruff is so significant and there's a lot of redness on the head, it is very helpful to ask for a topical anti-inflammatory or a topical corticosteroid, typically just for a very brief period of time. Usually people will need it for like 2 to 4 weeks and then they won't really need it anymore. And it's important for people to know, because I have this happen a lot too, that these anti-inflammatories for scalp redness, they come in solution and form and foam forms. Please don't have anyone prescribe a cream or an ointment for your scalp. That's just going to make a big old mess, okay? So you can ask for them in drop forms. There's also oils available. I tend to use this more for younger individuals because older folks obviously don't want their hair all greasy from an oil. But the beautiful thing about the oil is that it doesn't hurt when you put it on open areas. Okay. So, like a potential plan for scalp dandruff, I would say if I saw this patient come through my door, I would prescribe ketoconazole shampoo, tell them as best they can to try to use it 2 to 3 times a week. Let the shampoo sit on the skin as best you can for like 1 to 2 minutes, and then rinse it off, and then probably give a topical steroid drop to put on the spots every night for like a week or two, and then get off of it. Um, I can understand the challenges of, or I should say, I understand the challenges of bathing. Just across the board, and all of my patients, patients with Down syndrome and without. So we try to be very practical about this with this ask of like, okay, yeah, leave it on for 1 to 2 minutes. It is absolutely okay to fill up a squirt bottle of warm water and gently squirt the head and massage the shampoo in, and then go and hang out, go watch a TV show, go play, go do whatever you want for upwards of 30 minutes, and then you can go get in the shower and rinse it off. Okay. So we have a lot of people do that because sometimes standing in the shower for 1 to 2 minutes and not rinsing your head is just going to be a really tough thing to do. So I would talk with your care provider, your dermatologist about ways to make it practical. We've got lots of tools to do that. So I want to go next into psoriasis because I think for some people, bad dandruff is on the spectrum of psoriasis. Here is a psoriasis handout through Society for Peds Derm. We're working on one right now specifically for people with Down syndrome. But what is psoriasis? So it's where the immune system, woohoo, there we go, maybe interferon, makes the skin cells grow and shed too quickly and leads to red, scaly spots on the elbows, knees, and scalp. That's what it looks like for a lot of folks. Okay, so here's some pictures of psoriasis. Typically circular, usually very silvery white scale. Looks different in different skin types, and this is oftentimes, unfortunately, misdiagnosed as like a fungal infection. Here's a more extensive case of psoriasis. Oftentimes elbows and knees. But then I put this up because psoriasis can significantly involve the scalp. So if I were to see this person, I'd be like, uh-oh, I gotta look elsewhere for psoriasis. Here's more psoriasis on the scalp. Can happen in the armpits too. Okay, so this is my brain during clinic when I see so many things, and I've really had this happen a lot with psoriasis through the years because there's very limited information about psoriasis in people with Down syndrome. So let's just head to the lab just for a minute just to chat about some research with psoriasis. So right now we are so fortunate to have received an NIH Include project grant to study psoriasis in people with Down syndrome and specifically links of cardiometabolic disease with psoriasis. And so let's chat about this a little bit more. This is our team. Actually, today is like a grant day, and so I've been talking with actually everybody on this screen. Dr. Scotco, Nicholas, and I were emailing earlier today. Dr. Burdick is a family practice doctor here at Dartmouth. This is our awesome statistician. Dominic builds all of our cool data builds, and Jen helped him a lot in the beginning. Okay. So we are using Epic Cosmos data, and a lot of you guys might have heard of Epic because it's a very frequently used medical record system now across the United States. So they have data, well, let me stay on the slide. They have data repositories of a huge percentage of the Down syndrome population here in the United States. So, last we were looking, there are data points on, de-identified, I should say, data points on 150,000 people with Down syndrome in the US. So it's really cool. We can learn a lot about people with Down syndrome and what they're diagnosed with and how they're managed for their conditions through EPIC. Okay. So we received a grant to look first at how common is psoriasis in people with Down syndrome and what kind of treatments are they given for it and like how bad is psoriasis in people with Down syndrome. And this is a super busy slide, but I put this up here because like these are all the things that we had to show the NIH when we applied for our big grant. All of these thoughts on like what we wanted to look at. Okay. And then aim two for our grant is to say, okay, great. In people with Down syndrome and psoriasis, are they more at risk for type 2 diabetes, sleep apnea, being overweight and obese, and then potentially more likely to have heart attacks or strokes? Because this is actually things that we see in the general population if you have psoriasis, that it's linked with cardiometabolic disease. So we really wanted to see if that was the case in our Down syndrome patients. Okay. So results so far, and we're like, 7 months away from our grant being up. So I don't have all the data, but what I have this far. So psoriasis happens in about 3% of adults with Down syndrome and 1% of kids. And guess what? This is at least equal to the general population. So this is a common skin condition. It is 4 times higher in adults than in kids. Okay. And it increases as you go through life up until about age 45, and then it precipitously decreases the incidence of it. And we're trying to look at why that is. It's more common in men than in women. And it is more commonly diagnosed in people with fair skin compared to Black, African American, and Hispanic individuals. There are many ways to treat psoriasis. diet, exercise, topicals, phototherapy, and medications that you can put in your body both by pill and shot form. Okay. We wanted to see how it was being treated in our patients with Down syndrome. First, we looked that actually dermatologists predominantly manage psoriasis, but there's a lot of general practitioners that do. Okay. Why does that matter? Well, who do we educate about skin conditions and psoriasis? Who has access to dermatologists, right? And how severe is their disease that they would need a referral to a dermatologist? For treatments, topical prescriptions were given to 94% of our patients, and but systemic medications, either pill or shots, were given to 41%. And so why that matters, whoops, sorry, I didn't get to that slide yet. I will say that the most common topicals were corticosteroids, so 90%, and then salicylic acid, which is a common topical used to help thin skin, like that thick skin, okay? For systemic medications, apremilast or Otezla was given in about 8% of patients, and then Humira or adalimumab in 11%, okay? So why does that matter? Why do we care about how it's treated? Well, I'll tell you, there's no formal trials in any of these medications in terms of safety and efficacy, okay? We don't know how especially these shots and pills interact with the immune system in people with Down syndrome. And as you can see, 40% of people are being given medicines inside their body for the psoriasis. So that's huge. We don't know how helpful they are. What are the side effects? Okay. So, when we think about how severe disease is, if you are given something by mouth or shot, we consider that moderate to severe psoriasis, and almost 40% of people were being given those. So, this is a huge percentage of patients with Down syndrome have more severe psoriasis. Why does that matter? Well, what is the impacts of their disease on their mental health, on other autoimmune conditions, on their general health, specifically cardiometabolic health? And how does it affect their quality of life? These are all very hot button questions in the psoriasis research world in people who do not have Down syndrome, and none of this has really been talked about in this community. So, one of the most important things that you learn as you train in dermatology is that it's not just the skin, right? The skin tells us about how other conditions are affecting people's bodies. And specifically with psoriasis, it affects metabolic syndrome, diabetes, cardiovascular disease. Okay. So, interestingly, people with Down syndrome rarely develop heart disease like heart attacks and strokes. Okay. But my question has always been when I've seen these patients is like, okay, well, that's great, but what if you have psoriasis? Does that change? And that's what we're working on right now with this database to figure that out. And I could probably go on for another hour on our prelim findings, but I'm not going to do that because I'll just give a talk next year when we have it all fleshed out. But I hope that's helpful to kind of see, what we're trying to do at the NIH include to improve research for people with Down syndrome, not just looking at skin, but at their cardiac health. So let's jog back to the clinic and talk about alopecia areata. So alopecia areata, here's a handout for that. Okay. This is a autoimmune skin condition where your hair falls out, specifically on the scalp and oftentimes in circles, but it can be more diffuse to involve the entire scalp. It can also involve the eyebrows and eyelashes. Okay. So alopecia areata, we have seen through research, it is more prevalent, it presents earlier, and it may be more severe in people with Down syndrome. And we did a study a couple years ago really capturing this, that alopecia areata was diagnosed in 0.83% of Down syndrome patients, so about 1%, compared to in the general population, people without Down syndrome, it's 0.06%. So you have a 15 times higher relative risk of having this condition if you have Down syndrome. And this is a very common thing I see in my clinic. So remember the owls, remember interferon. We think this plays a pivotal role into why we see more alopecia areata. There's also other immune system genes on chromosome 21, one in particular called the autoimmune regulator or ARI gene, which we think is quite involved with alopecia areata. So there's a lot of work going into this research, again, out in Colorado, specifically looking at JAK inhibitors that impact interferon. And there was a clinical trial looking at JAK inhibitors, specifically tofacitinib, to treat alopecia areata and several of these other skin conditions we chatted about with. So alopecia is more common in people with Down syndrome who specifically have thyroid disease. And we did a study, here we go, headed back to the lab, that captured this. And this is the QR code to the journal article that was published, I think it was about, yeah, two years ago, that if in a patient with Down syndrome, and those specifically with Down syndrome and alopecia areata, they had an elevated risk of thyroid disease. So relative risk of 1.6 compared to if you just had Down syndrome and you didn't have alopecia areata. So that's a bit of a mouthful, but what I'm trying to say to you is if you have alopecia areata, okay, and you have Down syndrome, our recommendation at this point is that you really have to make sure that your thyroid studies are up to date. And in the box here below are the recommended thyroid study intervals for the pediatric guidelines and adult guidelines. Okay, so basically an annual thyroid study up until about age 21. And I would argue that if you are age 21 and older and you have alopecia areata, it should probably still be every year. We frequently talk about this in my clinic because there's very limited resources for people with Down syndrome up in the Northern Kingdom where I am in New Hampshire. And a lot of the Down syndrome clinics are multidisciplinary clinics are closed. They're too busy. And so I have a lot of patients come in for alopecia areata and they haven't had their thyroid checked in like 4 years sometimes. And so it's very important that you just make sure that your thyroid screening's up to speed. Treatments of alopecia areata, there's a lot out there, and I'm not going to go through all of these because it's a complex conversation, but I just want you to know that there are things that can be done for this condition, and you should go see a dermatologist to chat about these. Anything from topicals, intralesional steroid injections. We have techniques in my office that I think make them not horrible, and I have a lot of people who do quite well with these. And then there's oral treatments for this. JAK inhibitors kind of at the forefront of those right now. And I had several patients with alopecia areata and Down syndrome on JAK inhibitors for this. So as for a referral, okay. Let's chat about folliculitis HS. And I think this is about where I got cut off at the NDSC. So this is a huge topic, and I want to really spend a lot of the remainder of our 20 minutes chatting about this. So we have a Down syndrome specific folliculitis handout here. Okay, so let's just stop for a second. This is probably the most common skin condition that I see in people with Down syndrome who come and see me. All right, so this is a very, very common issue. What does folliculitis look like? It's oftentimes called body acne, which I think is pretty accurate when we're thinking about what it looks like. So it looks like tiny pimples in some people on the skin, little white heads, and you can kind of see how it happens around where the hair comes out of the skin. So sometimes it can be tiny bumps, sometimes it can be pretty big bumps, and we're going to talk about that. Here is more examples of folliculitis. Oftentimes happens on your bottom and your thighs. That's the most common place that I see it. The back of the neck and the upper back are also pretty common. So what causes folliculitis, specifically in people with Down syndrome? Well, we think there's a couple things that could make it happen. We see down here in the bottom the immune system, thinking about interferon, the microbiome. How does fungus or bacteria grow differently on our skin that make this more common? And then there's a potential link actually with amyloid, which you guys might have heard of from a lot of the research that's gone into memory loss and Alzheimer's and amyloid precursor protein. So amyloid precursor protein is on the 21st chromosome, and When more amyloid precursor protein is produced, at least in mouse models, we've seen that it actually clogs pores. It gunks up our pores, and that potentially leads to more folliculitis. I will tell you, it is almost never from a full-out bacterial infection, like a staph infection. I have cultured more of these bumps through the years, and I almost never get a bacteria growing. Okay. And so a lot of people are misdiagnosed with like, oh, this is a chronic staph infection, but it oftentimes is not. It's not incorrect to rule that out. So it's not incorrect for somebody to take a culture and make sure it's not an infection, but it is frequently more, I think, related to amyloid, this immune system dysregulation, and then the microbiome itself than like a true bacterial staph infection. Okay. So treatments for folliculitis, okay. Depending on the severity, all right, so for more mild cases, oftentimes just starting on a good anti-inflammatory wash is helpful. And some of, our favorites are benzoyl peroxide washes, a panoxyl 10% here on the photograph to the side, oftentimes is quite helpful for people with more mild cases. HIPAA I put on, this is more if there's a bacterial component to it. I have had some patients, even though there is no bacterial component, find it helpful too. Okay. So body washes, tea tree oil is also I would say anti-inflammatory, and I've had some people find over-the-counter tea tree body washes helpful. And then benzoyl peroxide and HEPA. Jogging back up to this top one, baths or showers, once daily or every other day. I would say one thing in our clinic is we spend so much time talking about feasibility of treatment plans and not giving too many things to do and really hearing people out. And so ideally it's happening once to every other day, but I would say with a dermatologist, we can be creative in terms of how you can space that out. So in little kids or people who do not want to take showers, doing very dilute bleach baths can actually be pretty helpful. And there's a fair amount of literature for this in the atopic dermatitis or eczema world. And then time in the swimming pool. I can't tell you how bad so many people's folliculitis got during COVID because all the pools were closed. So I do think swimming helps. I oftentimes say though that the chlorine, especially in public pools, can be very drying. So rinsing out after you get out is really important. But that does have an anti-inflammatory effect on these body pimples. Okay. In more mild cases, using topical antibiotics on the skin can be helpful. Clindamycin lotion is a common one that works pretty well. I use a little bit of an unconventional one for the clindamycin people, well, for the cases where clindamycin doesn't work, and I use metronidazole cream. It's actually a common rosacea cream, but I've found it works pretty well, especially for folliculitis around the armpits. Erythromycin pads are pretty nice because they come in like little makeup round pads and they're easy to hand to someone to like rub in an area of folliculitis. And I always pair a topical antibiotic with a wash or a soak to minimize bacterial resistance developing. For bigger bumps, and we're going to jog back on this when we talk about HS, there's a prescription medication called Resorcinol 15% cream that you can use on bigger bumps twice a day for 1 to 2 weeks to kind of get them to come to a head and get better quickly. This is a specialty cream that's made by a compounding pharmacy. I use Chemistry RX in Philadelphia a lot that makes this for me. I'm not sure where y'all go in California. I guess I could ask my friends out there. But this can be a very helpful rescue medication for big bumps. Then antibiotics by mouth. We got to be real careful with these. I have a lot of patients come in and they've like been on doxycycline twice a day for a year and their skin isn't better. Okay. I will say that in certain cases, short courses of oral antibiotics can be helpful, but we just have to be really thoughtful about this. Oral zinc is also something that's been used for acne, folliculitis, and HS through the years, and I do use this in my office. The biggest thing with oral zinc is you have to take it once a day. It can cause upset stomach, specifically decreased appetite, nausea, vomiting. And oh, I have a typo, sorry. It should say watch for copper deficiency, not what for copper deficiency. If you over supplement with zinc gluconate for too long, you can actually cause copper levels to go down. So this is really important that you like ask a dermatologist or a general practitioner who has familiarity using zinc gluconate for these skin conditions, but it can be very helpful for folliculitis and HS. I personally like to start on 30 milligrams. I don't find that we need to go up to some of these higher doses, and 30 has been helpful for a lot of my patients, and they haven't had stomach issues. For more significant cases of folliculitis, especially if there's a lot of blackheads involved, I've had patients through the years do very well with Accutane. Okay, this is a specialty acne medication, and you definitely need to chat with a dermatologist about it. But I think that that should be on the list of considered treatments in more severe cases. So let's move over to hidradenitis. So hidradenitis, there is a specific handout about this. Here's the QR code. And this can appear in a couple different ways. And I would say folliculitis and hidradenitis, for many patients, it's on a spectrum where it's a little, either it's folliculitis or it's HS or it's somewhere in between. And we talk about that a lot in my clinic. Um, I think people with Down syndrome kind of have a specific look to their hidradenitis, and we're working on it. We just have to like better describe this in the literature. Okay. But you're going to see that a lot of the treatments overlap here too. So, hidradenitis can look like bigger bumps or boils on the skin. They can turn into kind of dipped down scars, and they can be sheets and sheets of comedones or blackheads. Okay, those are some key features of hidradenitis. It can happen specifically in the armpits and the groin and underneath the breasts, and every now and then other areas. But those hidden spots, armpits and groin, are like top spots for hidradenitis. Okay. Here's some photographs of hidradenitis in the groin. On the underside of the breast is a very common location. It can happen in all different severities and stages. In dermatology, we oftentimes talk about Hurley stages. Hurley 1, Hurley 2, Hurley 3, and you can just kind of see as we move along that the inflammation gets deeper and the scarring more significant. And this is what I mentioned earlier. It can oftentimes be on a continuum, on a spectrum. So someone might start out with folliculitis and then go into HS or vice versa. And so these are examples of patients starting to develop early signs of HS on their groin area. Both of these patients have Down syndrome. So let's head to the lab just for a minute to talk more about hidradenitis. There's been some really nice studies done by Amit Garg, who is a hidradenitis specialist in New York, looking at it in Down syndrome. So he did a huge population cross-sectional analysis. It was now probably about, my gosh, it was like almost 8 years ago, and found that hidradenitis is much more common in people with Down syndrome, 2% in those with Down syndrome compared to 0.3 in those without, which those are big numbers. It presents earlier in life from what we can see. And so in the Down syndrome population, you're seeing it spike out kind of in when you're 10 up until your late 20s, whereas in adults, it's diagnosed kind of later on, 20s into 30s and 40s. And I won't go into the ins and outs. There's some confounders with that and arguments, but I think in general, I've noticed that in my clinic that I have a lot of very young people with Down syndrome diagnosed with HS. So this data was so compelling that when they talked, or I would say when the United States and Canadian HS societies formed some guidelines about how to screen for HS, they recommended screening people with Down syndrome annually for HS. They did not give an age as to when to start. One of our Down syndrome skin groups kind of loosely came up with, hey, you should probably start around 8 to 10 years old. And all screening is for HS is to look in the armpits and in the private area. So I try to educate general care providers to look for that. And I just want to educate you guys to just make sure you're looking at the armpits and groin area for any signs of HS, because when it's treated earlier, it has a much better response to treatment. Okay, so check the armpits, groin, inner thighs, under the breast for any signs of this condition. Treatments for hidradenitis. You're going to see a lot of repeats here with the folliculitis. So trying to bathe with some frequency, using washes like benzoyl peroxide, Hibiclens. Wound care and clothing. I spend more time on this in the clinic, but I think that that is important. There are some specific bandages that work pretty well, especially for lesions that leak a lot more. This is not really talked about too much and should be more. Okay. Topical antibiotics, we chatted about that before with the folliculitis. These also can be helpful with HS. Oral antibiotics, again, we have to use in caution. Oh, I'm sorry about that. And then resorcinol, we chatted about that as a rescue medicine for really big bumps. Okay. There's a longer list though for other treatments for hidradenitis, and I think it's just good to know about these so that you can potentially bring them up. So hormonal treatments specifically for women, such as combined birth controls and very low dose spironolactone, can be helpful. And all of this is on the HS Down syndrome handout too. Systemic zinc, like we chatted about, Accutane in certain cases, not always helpful in HS, but sometimes in people with Down syndrome and HS it is. And then specifically talking about biologic treatments. JAK inhibitors in the Colorado study, HS was included. There were not a lot of people with HS, but there are some reports of JAKs being helpful. Humira or adalimumab, infliximab, sisakinumab, which is Cosentyx. Okay. I would say of these, I do have some patients on these. I tend, if we're going to talk about biologics that are not JAKs, I have tended to use more sisakinumab or Cosentyx because the infection risk is lower in this biologic. And there is also not the associated risk of blood cancers, hematologic malignancies, which is linked with adalimumab or TNF alphas. I'm saying some of this, and this might not be useful for the majority of people on this call, but I think that there are probably some people on this call who either have this type of HS or have loved ones with HS. And I think it's just important to chat a little bit about these biologics. Okay. Intralesional Kenalog, that means putting steroid into big bumps with a tiny needle. I actually do this a fair amount in my clinic, and I think I've never had it not be a positive experience for our patients. We have lots of tips and tricks on how to do that pain-free, and is super helpful. Okay. Surgical treatments, there are dermatologists who are now really taking the baton to try to offer better surgical treatments for HS. I have not had a lot of my patients with Down syndrome pursue these yet, but I think that that will be more of an option in the future. And then laser hair removal in these areas can be quite helpful. So I hope that's helpful just to go over that big menu. All of those things should be chatted about with you if you have hidradenitis. Okay. So you've got to talk to a dermatologist if you think that you have hidradenitis, because there's so many things out there that can be done. We have tried hard to push advocacy, especially about hidradenitis and folliculitis in the Down syndrome community. This is an awesome British Journal of Dermatology article that was written by Alexis and her mom, talking about what it's like to have HS and Down syndrome. Alexis then followed it up and did a podcast about her experience, and this is the link to the podcast. And then lastly, I just want to spend a couple minutes about foot fungus. Here is a handout about fungus or tinea. This is also a very undiagnosed thing. So tinea pedis or athlete's foot is, I would say, very common in both kids and adults with Down syndrome, at least in my clinic. And again, you come in for something else. You come in for alopecia areata, and I ask to take your shoes off, and you're just like covered in foot fungus. Okay. So when it's in the nails, it's called onychomycosis or nail fungus. Okay. And it's a hidden spot. It's a neglected hidden spot. And the nail fungus can be tricky, but the foot fungus, like the scaling on the bottom of the foot and in between the toes, that is definitely something that we can help with, okay? And it's super important to try to treat because it puts you at risk for other skin infections and it's itchy and annoying, okay? So there are over-the-counter treatments. Clotrimazole is probably one of the more effective ones, but then there's also terbinafine cream and spray. There's tinactin sprays. And we oftentimes talk about doing these as best you can, usually just once a day at night for about 2 to 4 weeks to get the foot fungus in between the toes, bottom of the feet, excuse me, better. There are prescription topicals for foot fungus like keto, conazole. You've seen that word a lot on this presentation. Econazole, cyclopirox. Okay. I have found for toenail fungus specifically, the topical drop that tends to work the best is ifaconazole or Jublia. I will tell you it's very hard to get that covered by insurance in the beginning, so you oftentimes have to try some of these other topical creams before you get that. But I've had pretty good success with Jublia. Children in general tend to do better with topical nail treatments than adults. I would say adults and kids, if it's just on the skin, they tend to do well. But if it's in the nails, the kids tend to respond better to topicals than the adults. Okay. And then there's oral treatments, and I've treated some of my patients with this. The most standard oral treatment for foot and toenail fungus is terbinafine. And there are risks with that medication. You specifically have to watch liver function, but overall, man, knock on wood, I've not had many side effects with that medication. It does not have an astounding 100% cure rate, meaning that while people will respond to it after they've been on it for 3 months and might have clear nails, the chance of it coming back is probably about 50%. And that is depressing. But I would say oftentimes what we've done is we've used oral terbinafine and then had like a topical cream just to make things stay doing well, okay? Or we've done terbinafine and then we do a little bit of Jublia here and there to keep the nails doing okay. So in summary, everyone's different on how I would prescribe this, but there are some good treatments out there and it does not need to be a neglected, forgotten about problem. Okay, in general, trying to keep the feet dry, changing socks frequently, wearing socks that have a wicking material to them that remove moisture from the feet, and then considering like an antifungal foot powder for the inside of the shoes and the feet, but more so the inside of the shoes can be very helpful. And then I always like to say you got to keep the shoes dry too. Don't just throw them sweaty into a dark closet just to kind of grow more fungus. We got to have them out in the open and consider using an antifungal powder in them. And then considering a maintenance treatment after, it has gone away because it can come back. So our roadmap, just to kind of, I think oh my gosh, I'm 2 minutes over. Just to kind of jog back, we talked about 6 big diagnoses in the clinic. We dipped in and out of the lab to highlight some research that's going on in the Down syndrome community. Here are our big 6. I just always like to give a shout out to my colleagues at the end of my talk. So this is Christy Holland. She's out in Wisconsin. Her and I lead the Pediatric Dermatology Research Alliance Down Syndrome subgroup. Okay. Emily Gurney, who's in Colorado. Irene Lara Corrales, she's up in Toronto. We've worked together now for about 4 years to really try to make differences in skin in people with Down syndrome. These are all the amazing med students, now residents, some of them soon full dermatologists who have helped us with projects through the years. All of these women have worked mostly for free to do all of this research. The Pediatric Dermatology Research Alliance, I just have to say, has been incredibly generous to the Down syndrome community. They have donated and given us thousands of dollars to do all of this work. Mike Siegel, Jen Dawson, and Catherine Davenport. Obviously, the NIH Include project has supported a large part of my research career and the amazing research team I'm a part of right now. Powers in collaboration, and that's for sure. So I just wanted to pause there, and I'm happy, Michelle, to answer some questions. I'm not always great at like toggling in between the chat.
Not a problem. I can
And
read them out loud for you.
yeah, that's great. And I'll just like unshare my screen so maybe I can kind of look at them a little bit easier. But I hope that's helpful. I always feel like it's too much of a whirlwind, but I just want to try to give as much information as I can about hot button topics. So I hope some of this resonated with each and every one of you with skin challenges that you've encountered.
I believe so, because the questions are coming in. So the first one, this is Fatima. I apologize. I was a few minutes late. What was the first skin condition that you covered? And I'll also ask this while we're on that topic. Will it be possible to share these slides when we share the recording of this webinar?
Yeah, sure. So I can give you guys, I can give you slides that basically don't have any patient photos on it. Like
Okay.
every photo that you see on here, I've obtained like written consent from the patients, or they're just like, from Visual DX, or I have the website linked with them. But I'm happy to give you guys the ones without any photos because even though I have written consent and like the generosity of these families, I just worry about giving them out. So yeah,
Absolutely.
absolutely.
Okay,
And I think
perfect.
you guys
Thank you.
find the treatment slides more helpful than anything else than like all the photos.
Okay, perfect. So I'll share that. So Fatima, you'll have the full deck so you can see which one was first discussed. Do you recommend seeing any pediatric dermatologist or someone with experience treating children with Down syndrome?
So this is a project that actually Joaquin Espinosa and I were chatting about that we need to like through the Global Down Syndrome Foundation or something, just like have a registry of dermatologists like who would do because I will tell you, like, yeah, we have some amazing people throughout the US, but I have no way of being unless you guys like email me and call, which my secretary gets calls every week. Like, do you know anyone in Arizona? And then we like find people. So I would say, in my experience, obviously I'm a little bit biased. There is a lot of energy and enthusiasm in the pediatric dermatology community to help people with Down syndrome. And I would say, like, we're at all the national talks. Everyone kind of knows hopefully what we're doing. So I would encourage that. And I think pediatric dermatology is a very small world. So if they have questions, they know how to get a hold of me. And you guys in California, you have some of the best, at UCSF and Stanford. And,
Mhm.
I can identify a bunch of people in that area who I think would be great. And even if you just get your foot in the door into some of those departments, um, I think you will naturally fall in the hands of people who are experienced. I mean, I know that there's an adult, it's hard. Like I can't just like blanketly give out names on a webinar, but there's a wonderful hidradenitis physician at UCSF in the adult world who I'm like doing a project with right now. So yeah, so I would tell you to try Pete's Derm, but if you are too old for that, starting at if you haven't found success in a local dermatologist, working with an academic dermatologist in one of the medical centers near you would probably be helpful. I hope that's helpful, Michelle. I don't know if I'm just droning on.
No, that's helpful because I'm making note of that for my own son. We scheduled an appointment in July and next available is December or January of next year. So the number of dermatologists available in general is far
That's
and few
horrible.
between.
I know.
Yeah. And so no, so that's helpful to
Yeah.
know. And I'm making note of that for myself. And I'm sure that's helpful for everybody else. Next question. Thanks for taking the time this morning to discuss skin conditions. We appreciate all of the information you've provided. Wondering about treatments for milia around the eyes and hands. Is milia a type of folliculitis?
Oh, milia. Oh,
Oh,
yeah, sure. No, milia is not a type of folliculitis. This is a great question. So, milia are actually super duper duper superficial cysts that happen oftentimes around the eyes because of like rubbing of the skin. And I would say people with Down syndrome, there's been case reports of this through the years that you can get kind of more milia on your palms of your hands and the backs of your hands. We don't totally know why that is, but it's not considered a folliculitis. Most of the times, the milia, when it's on your hands, it's in smaller children and it will go away with time. One of my favorite treatments for milia is number one, identifying why are we eye rubbing? And if it's not for allergy reasons or an eye condition, if it is more of a behavioral pattern, like working with an OT to help minimize that, because we can treat the milia, but if we don't treat the underlying symptom, they keep happening. And then using gentle, what are called retinoids or vitamin A topicals, such as adapalene cream or tretinoin 0.025% cream, using those correctly around the eyes a couple times a week at night can very gently exfoliate the milia so that they go away, like they peel the milia off. Um, yeah, I could go on and on. Milia are not syringomas, which I won't chat about, but like there's lots of things around the eyes in kids and adults with Down syndrome. But I hope that's a helpful start with what milia are.
thank you. Can the thyroid related alopecia be addressed or cured?
So that's a great question. So it's not it's tricky. It's not we don't know. We know they're associated. We don't know the causality of them. Okay. So um I do think in some patients, having optimal control of the thyroid does improve the alopecia areata. Okay. But I also have patients with beautifully controlled thyroid and they still have alopecia areata. In terms of like, can it be cured? I would say cure implies that we could treat it in a way and then take away that treatment and it would never come back, which I don't think is possible at this point. Okay. But there are more helpful treatments now for alopecia areata, specifically some of the topicals, and then talking about JAK inhibitors in certain cases. So I hope that that's helpful. So it is always helpful to screen the thyroid and make sure the thyroid is like, doing well, but it doesn't necessarily mean that your alopecia areata will be reversed.
Can Hibiclens be used on the genital areas? Specifically, I've seen severe folliculitis on the scrotum area. I've been provided mupirocin.
Mm-hmm. Yeah. So it can be really, I mean, from the neck down, HIPAA cleanse is okay. You never want to do it neck up because of potential ototoxicity in the ears. It can be used on the private area. You just have to make sure that it is very well rinsed off. Mupirocin is a topical antibiotic. It is typically more so for staph infections, bacterial infections. I have seen it helpful in some cases of folliculitis in people with Down syndrome, but and this is like always so hard on these because I'm not like seeing it, because there's certain types of folliculitis I might be like, oh yeah, mupirocin might work well. But so it could be helpful, and I don't um, for folliculitis on the scrotum, depending on what it looks like.
And piggybacking on that question,
Mhm.
can Hibiclens, I'll get that pronunciation right one day.
No
Can
worries.
that be can that be used as a daily cleanser for folliculitis?
So I would say it depends on the dryness of your skin and how sensitive your skin is. Sometimes daily HIPAA cleanse can be like really irritating. So yeah, depending on the sensitivity of the skin of the age, you could consider doing it daily. or like every other day to 2 to 3 times a week. Mhm.
And what over-the-counter soap do you recommend for daily use?
Oh yeah, just like in general, just a general daily use soap. Um, I take care of people with super sensitive skin, so we're all about like Cetaphil Gentle Cleanser, Dove Unscented Bar Soap, the generic versions of that. Those typically work quite well. Yeah. But in certain cases, I'll use dial soap or other specific cleansers for skin conditions. But yeah, I hope that's helpful and affordable things.
And they sell those in Costco. Um,
Yeah, exactly. You can get your chicken at the same time, right?
how helpful is laser hair removal for HS, and is it covered by insurance with the HS diagnosis?
Yeah. So I would say, man, I wish there was anything for HS that was a slam dunk. I kind of say, for almost all treatments, it's like kind of 50-50. Um, I I am somewhat fortunate that the laser hair that is oftentimes done at Boston Children's Hospital, which is where I'll refer my patients, is covered by insurance, but oftentimes it is not. I would say, in general, at an academic medical center, they may have more swing on getting it covered for HS, especially if you're able to document that you've tried and failed numerous treatments, standard treatments for HS, like the washes and the clindamycin and the antibiotics, and you're able to document why you're not able to pursue some of those other treatments. But it is a struggle to get it covered. Um, it is also, I personally like sending people to a provider who's familiar in the pediatric space with doing laser hair removal because it can be pretty painful. And I feel like my colleagues, at least down at Boston Children's and some of the surrounding places where I am, get that it hurts and really try hard to make it not hurt, and they're good at that. Um, there are a lot of kind of local med spas and things like that that will offer laser hair removal, which I get kind of worried about when we're talking about treating an underlying medical condition, skin condition. So I think in summary, it's probably good to go to a more subspecialty center. They will have more familiarity with making it a positive experience and hopefully better success with getting it covered by insurance.
In addition to the severe bumps from hidradenitis, my son
Michelle,
has.
you're crushing it, by the way. Like you're hired. You can just say HS.
Okay, that'll make
Yeah,
it so much easier.
yeah.
My son has severe itchiness in the scalp, but not much flaking, and nothing seems to work. Any suggestions on what can provide relief?
Yeah, so I'm gonna say something crazy and I don't want everyone's heart rate to go up, but like I know it sounds bonkers, but anytime I hear no flaking, super itchy, I'm like, OMG, let's just make sure there's no lice, because the number of times I've seen that has been like a lot. Okay. So I'm doubtful that that's what it is, but just make sure. And then I would talk about using some of those drop topical steroids just for like a brief period of time, like the clobetasol solution or clobetasol foam. And then I would still potentially give you one of those like anti-dandruff shampoos, specifically the cyclopirox, I think is a little bit more helpful when it's just itch and not as much scale. And then I would also ask the person evaluating them to just look for any evidence of hair loss or underlying redness to the scalp, just to make sure that we're not missing like another underlying like hair condition.
Okay. What about when they have several skin things going on at a time? Is there a few things that do a good job at addressing multiple issues? Sometimes I feel like they give me so many prescriptions and I can't remember what's what.
Yeah. So that's an awesome question. And I'm all about like, multiple birds with one stone, even though I hate that phrase. Um, what I have tended to do is when we identify all the potential things that we could help. I usually say, let's pick like one, maybe two things to address, get that down, and then see me back in like a month or two. And then we're going to go working on other things if those things are still there. Um, I think that that is honestly a better approach because a lot of the times it's like they have dandruff, you have foot fungus, and you have folliculitis. And it's like, what? Like, where do I start? And unfortunately, it's a little tricky to overlap some of those things. One thing, in that first visit where we'll may identify a bunch of things, not only will we pick one or maybe two, but we'll just like chat in general about daily routine and personal hygiene and like how's that going and who's helping and like how can we maybe build some of those skills so that as we address potentially more skin things, like how that won't be like burdensome. Um, but a lot of the times, at least in my clinic, we are oftentimes talking about addressing folliculitis, hidradenitis, and dandruff first. That those are like the biggies that we start with. Because especially the dandruff, we can usually get that under control like pretty well after a month or two, and then we can just like let that chill and move on to something else. So I hope that's helpful.
Um, are you able to share the name of the UCSF doctor?
Oh, let me tell you this, Michelle. Can I just like message her? Because I've had that happen before to me, and then I don't know someone did that, and then all of a sudden I've gotten like 20 phone calls in my clinic. So let me just like chat with her because she might have other people too. Do you know what I
Okay.
mean? Yeah. Yeah.
Yeah, that would be perfect if and then if you can just email
Awesome.
me that
Yeah.
information.
And she's
Thank
great.
you.
She's actually, so the project we're working on is we're building a whole curriculum for the American Academy of Dermatology to treat dermatologists on how to take care of people with physical and mental disabilities. I'm like so pumped about this.
That's amazing.
Yeah, yeah. And so anyway, so yeah, she's wonderful. So I'll do that. And then actually,
Okay.
Michelle, if you want, what might be helpful, I know we were chatting a little bit before, but just like give me a rough idea of all the catchment areas that you have,
Mhm.
and I might even be able to give you guys more names, um,
Perfect.
just
I
thinking
will
through
do
the
that.
areas. Mm-hmm.
Okay, I will do that. Thank you. That will be very helpful because we're so spread
Mm-hmm.
out and there's so many
Yeah,
facilities, but yet it's still
right,
hard to find a dermatologist.
right, totally.
Um, the folliculitis, what's the
Mm-hmm.
best way to treat that? I saw the medications, ointments on the slide, but which do you want? Which do you want to start with?
Mm-hmm. It depends on the severity, and I know that's an annoying answer, but like oftentimes, if someone walks in my office and they've never tried anything, I will say, okay, let's start with the benzoyl peroxide foaming wash. Try to get that on 2 to 3 times a week. And then oftentimes I will start out with like clindamycin lotion if you haven't tried that, because that doesn't really hurt to put on. And I have a lot of people just like squirt a little bit of the lotion on one of those makeup rounds, like makeup remover rounds, and then you just spread it with that. Okay. But again, this is like, I need to see it because if it's like all over the place, like I have people come into me like, someone told me to use Clinda lotion. I was like, well, that would be on 50% of your body, so that's not going to work. So if it's just a small area, like we'll start with that. And then maybe some of that resorcinol for like really big bumps, you know. But if you're more severe, then we're just gonna like jump right past that. But I would say that's a good like starting point for a lot of patients. Hmm.
I've heard Selsun Blue is good for fungals. Do you recommend as a gentle preventative measure?
Yeah, salsa blue is great as an antifungal, but I use it for dandruff, which is antifungal, and I use it for something called tinea versicolor, which is a different fungus rash we didn't chat about, like on your back and chest. It can work really well, so I am not anti that. Have I ever used it for people to like wash their feet with as like an antifungal? Um, No, there are certain, here we can go real in the weeds. There are certain types of acne that are more yeast driven where I'll use that, but I can't say that I like recommend it all the time as just a prophylactic antifungal. It's more treatment specific for the fungus that a patient has.
My stepdaughter, who has Down syndrome, has recurring lip cracks, which seem to worsen during the winter. Any treatment suggestions other than Aquaphor ointment?
Yeah, I actually have a whole handout about this, and this was so annoying that it like didn't make the top, the quick six, the big six or whatever. So if you go to that pediatric dermatology derm handouts, there's a handout specifically for rashes around the mouth. And that, what you're talking about, that's called angular cheilitis. And there's a section on that handout about it. Um, and so oftentimes when like moisturizers aren't working, it's because there's a secondary like bacterial or fungus infection like in the corners of the mouth. And so oftentimes giving a topical antibiotic like mupirocin or a topical antifungal like ketoconazole is helpful. But that's a perfect case where I'm like, I can't totally tell you exactly which one because I have to see it, but now you know the name of it. Go into the doctor with the handout and be like, I think they have this. And ask for help with it because that is a super common problem. Also, too, just like another pearl aquaphor has an ingredient called lanolin in it. It's derived from wool, which like sometimes if chronically used in the same area on the corner of the mouth won't be super as effective. So just, think about using a different ointment like Vaseline or CeraVe healing ointment or Cetaphil healing ointment. Vaseline, you have to be careful because they like sell those super cute little containers, but it's like rose hip lavender. And you're like, oh, this smells so nice. But those things are not helpful, like for really bad dry skin. So just buy like plain or coconut oil is actually really helpful, like in the corners of the mouth, because it has antibacterial and anti-yeast properties to it. So.
Writing
You
that down.
identified the thing that I cut. Ah, so many things. Yeah.
Can psoriasis occur on the eyelid? And if so, what other treatment suggestions other than hydrocortisone cream?
So the answer is an emphatic yes, it can, especially in kids. Um, and the answer to that question is tacrolimus. I'll just write it in the chat.
Perfect.
Tac, depending on the, oops. So if you're 2 to 16 years old, I'm going to send it in a second. Tacrolimus 0.03% ointment. And I'm sorry, it's 15. If you're 16 and older, it's tacrolimus 0.1% ointment. That is like the safe topical to put on the eyelids, both for like eczema and psoriasis. You don't want to be putting chronic hydrocortisone. Um, I would also say without seeing photograph of it, like it could even be like dandruff too, because like that can happen here. It could be eczema, but absolutely psoriasis can happen on eyelids, and that tends to be the most effective treatment for it.
Perfect. Can HS go away on its own, or does it have to be treated early? And then at what age is it the most common?
Yeah. So I've had some, and like I've been in my own practice at Dartmouth now for 7.5 years. And then, in residency. So I don't have the advantage of like 30 years. But I have seen it get better in some of my female patients, like once they're past their like early to mid 20s. And I think that that's because there's more hormonal impact on female patients and the hormonal impact of HS. I have seen it get a bit better in some men. but I've had others where it stayed. It's so hard. I don't have a crystal ball. I have found that in patients who have lost weight, um, and I didn't go into this, but like sometimes metformin or the GLP-1 and weight loss can be helpful with that. I have seen HS really improve with weight loss and optimizing glucose management. Um, I tend to see it the worst in ages, I would say 12 to 25. Yep. But I've seen it start as young as 7. Hmm.
Yeah.
Yeah. But I do think there's something to like the turbulence of the hormones like during those years. Hmm.
What shampoo do you recommend?
I guess it would depend on, you know, like what I'm treating. It's hard. There's so much with shampoos that I get this question a lot, just like in my general clinic. I'm like, I don't know your hair type or your hair color. So, in general, if it's not for a medical condition, I typically say, like, I would ask your person who does your hair, your hairstylist. I would say for more gentle, over-the-counter anti-dandruff shampoos, in addition to like the Head and Shoulders and Selsun Blue, um, CeraVe and now Cetaphil and Vanicream, they make a zinc-based anti-dandruff shampoo that is like really awesome in little ones, and it's not very drying. So that's good brand. Um, and then I was just looking at the chat for a sec. And Dove makes a pretty good anti-dandruff shampoo, but I don't have like explicit ones for like daily shampoo. In general, even with people with sensitive skin and like atopic dermatitis, I don't find that shampoo has a huge impact on them. Mhm.
Is baby shampoo okay to still use on older children? Is that still
Yeah,
gentle enough
I
for,
think that's fine. Yeah,
okay.
I think that's fine.
That's kind of been what I've defaulted to because I'm so worried
Yeah,
about anything else being in it and
yeah, yeah,
irritating a seborrheic
yeah.
dermatitis. So I've
I
just kind
think
of
that's okay.
defaulted to that.
We just gotta be careful in that like the baby thing can get real gimmicky real fast and real expensive,
Okay.
you know. Yeah.
Perfect. And we are actually getting towards the end of the questions. We have, let's see, a couple more. So, my son has chronic open sores on the corner of his mouth because of constant drooling. And I apologize, my dogs are barking in the background. Um,
That's
we've
okay.
we've tried so many things, including Botox, to help stop the drooling, but nothing has worked. What else can we try?
Yeah. Gosh, I'm so sorry to hear all that. I mean, I would say that does sound like angular cheilitis, like what we were chatting about earlier. Um, I mean, you've probably tried so many of the things I already chatted about, and you would want this under the supervision of someone, but sometimes like a 3-day course of oral fluconazole, like which is an anti-yeast treatment, sometimes can get some of the yeast that's festering in that area to go down. Um, the Theraplex products, I just put that in the chat. That was like the super duper thick barrier ointment. I have found that helpful in some resistant cases. And then this is probably this has probably already been chatted about with you, but glycopyrrolate. So glycopyrrolate is an oral medication that can be given that can minimize oral secretions. I use it for sweating all the time. That's just a thought too. I've seen that in some of my patients with significant oral secretions. And then you've probably already worked with like a good speech pathologist, just trying to increase oral motor tone itself to try to help with that. Making sure that you have routine, excellent dental care, because I do think like bacterial yeast infections, like inside the mouth and the gums, teeth, etc., can contribute to that recurrence.
And so we have two last questions, and then we'll wrap it up because I know that we're going quite a bit over. Um, for clarification on the previous lip question, the crack on
Mhm.
the lip looks like the lip is splitting horizontally. and it's
Mm.
typically on the bottom lip.
Yeah, so even though that's not like in the angle, I would think of that similar to angular cheilitis, and you can use a lot of the same treatments. Yeah. Yep.
My
So,
son has toe fungus and he complains of the pain on his toes. The doctor told me that toe fungus doesn't hurt. Is that true?
so, man, I would say like, yeah, it could. It could certainly itch and burn. So, I don't know. I guess if someone told me that, I would like really need to examine it and see what it looks like, and then just get a better understanding of like what, like, try to understand what the pain is, right? Because pain can mean different things to different people. So, I would say foot fungus can be uncomfortable. It can itch, it can tingle, it can burn. And if it's bad enough, it can cause cracks in the skin that can become infected. Um, yeah. So I would say that needs to be like, if I were to hear that, I'd be like, uh-oh, like, what am I missing? But I would also say, like, if the feet are totally clear, we need to be thinking of other things. So yeah, my answer to that would be like, yeah, it could hurt. Let's figure out what the pain is. So shea
Um,
butters are okay. Yes, they are. They are. I don't have a
is there,
specific brand, but they're awesome. Shea butter's
I
awesome.
was I was just going to ask if there's a specific brand, and I guess I'm piggybacking on that because I see so many that have fragrances added to it. Do you recommend going fragrance free versus, or is there a difference in them at all other
I
than the
do
fragrance?
in general, but just make sure like if it's fragrance free, just flip the ingredient, like flip it over and look at the ingredients. And if it's like 3 paragraphs long, even if it's fragrance free, maybe put that back. You know? So the biggest culprits for fragrance additives, and again, you're talking to a pediatric dermatologist, so like real sensitive skin is like lavender is like the rage, and that can be a real troublemaker for lots of people. So just try to, and the other thing is when you look at ingredients list, they're going to be in order of like how much something is in there, right? So if there's an added fragrance, but it's like way down at the bottom, that's going to be better than if it's like lavender's ingredient 3. So, yeah.
That's really helpful because I just trust the fragrance free and don't even look. So that's very helpful.
Yeah. Sadly, you'll flip it over and it'll be like fragrance mix. And you're like, oh, okay, thank you. Yeah. So.
Well, thank you
Yeah,
so
you're
much,
welcome.
Dr. Rourke.
I
This
like
was
love looking at all
amazing.
these pictures. I've been intermittently kind of goofy smiling because I love all these photos that are up.
It's like a little Brady Bunch collage of our
Yeah, I love it.
family.
So, yeah, my pleasure. Happy holidays. I know it's early to say that, but I won't see you guys. So,
Yeah, thank you.
yeah,
Happy
you're
holidays to you.
welcome.
And as always, appreciate you. I've seen this presentation, what, 3, 4 times now, and it's still eye-opening every single time.
Yeah, no problem. My pleasure. We try to keep building on it because we're still trying to do more and more for everyone. So.
Oh,
So
one
I hope to
last
see some of you
question.
guys in Orlando. My kids are already like so excited for this.
I know I get to see them again. And
Yeah.
before that, though, one more question is
Yep.
the
Sure.
study as it wraps up, where would we be able to find the results of the study once they're available?
Yeah. So honestly, Michelle, I'm actually talking to Kate O'Neill and the folks at Lumind, although now
Okay.
they're like NDSS, so I'm
Yep.
trying to navigate all that. That I'm gonna give a webinar through them
Okay.
in like April. Yep.
Okay.
And
I'll
then
reach out to Kate then.
we'll have like posters at Dismig and all that. But yep, so and if you guys and Michelle, if you have other ways that you think I should try to distribute results, but I gave a talk last spring through Lumind on like just the RO3, talking about the NIH findings. And so we'll give another one next spring, and then any other thoughts you guys have, because that's a big mission of mine. We can't just like do this research and like publish it in academic journals. Like we need to get it to you guys. So yeah.
Yes. Yeah, and I'll be happy to disseminate that for all of our
Great,
families once it's available.
great.
Perfect.
All
Thank
right,
you
you
so much
guys.
for being here, and
Yeah, you're
thank you to everybody
welcome.
else for joining us. Have a wonderful day.
You too.
Bye.